right. It's great to see you guys.
It is great to see you too. What
the
hell happened to Ritu?
Yeah.
Somebody ate Ritu's face. Do you hear something, Mike?
I see something looks a little bit off from him.
I'm hearing.
I'd like to see you try to drink out of that.
Join me at the dark side of the force, Luke.
That was lame.
That was not that good.
No.
Darth Vader's a Michigan grad too.
Yeah. Well,
now that makes sense.
Yeah, I totally get that.
That definitely seems appropriate.
Well,
oh my God.
So he's going to keep it on. Okay,
keep it on the whole show. Well,
I thought it was a little fun gag to start it off with, but he won't take it off.
Drink with this.
Well, he's going to rapidly figure out he can't drink.
Yeah,
he's going to start seizing if he doesn't get that thing off soon.
Yeah. What's up, Kevin? Thanks for joining us in the chat. Appreciate that. Good to see you guys. So, again, like we said in the little cool logo thing that I made, by the way, you guys like that, right?
That was awesome, dude.
I know, it's pretty good. I got some.
That was a very bright pink.
Yes, it's very neon.
Yeah,
yeah,
that's good.
I see Brandon Means slid in here, and I thought about seeing if he wanted to join us, but I figured he was probably better off to heckle us from the crowd.
It's true. Well, as long as he's here, the snark was we'll make sure our snark titer is good.
Yeah,
I appreciate that.
Yeah,
got to keep some good Aggies out there.
Yeah, for sure. Well, what's been going on, you guys? Have you anything? Is there anything new going on? Or
I don't think so. It's kind of boring, normal stuff.
Yeah, same
Just
here.
Kind of not very busy at work. Not a whole lot going on.
Yeah. Well, actually, depends on your definition of work. Because at the emergency department, I ain't very busy. But
hey, there's a lot of discussion going on about that right now.
So did you, Ritu? I know y'all have had. I don't know. What are you up to in your area count wise?
The state is at 999.
Let me pop something up. I'm not sure where Texas is. I know my county is at 73. Which
Texas is bigger because that's what Texas does.
Everything's bigger in Texas. I was just looking at the latest little graph that was on the news there. Station to remain unnamed, I should say. And Oregon was down bottom, the third from the bottom for cases. So still pretty low.
You know what you ought to do? You with the sharing capacity.
Oh yeah. What do you want?
Flip over and pop up that Johns Hopkins dashboard. That is an awesome dashboard.
All right. Well, hold on.
I don't use that one anymore.
Yeah. We've been using Domo, but
I've been using the domo.com one.
Well, I'll tell you what, let's take a look at both of them and we can compare and contrast. And I will even send you the link that my county has. I'm very proud of it.
It's like your link, actually. You posted it, but do we really want to put this up? I mean, I thought the whole point was a little bit of a.
I was just merely discussing the, the infographics, but sure. Okay.
I'm just saying, I don't know.
Oh, why does it do that? That's the worst.
Wow.
It's literally.
So anyway, Ritu, I thought y'all had more cases initially and then kind of plateaued.
Yeah, we were ahead of you. We had
you were.
Our first case was February 28th or 29th or something like that. Andy McCoy.
Hey, what's up, Andy?
Dude, you know what? Can you get Andy do you have a mic hookup? We should get Andy to join us.
From Seattle. They haven't had anything going on.
No, they haven't had anything go on in Seattle at all. So we were ahead of you, and then we were watching our friends Andy and Mike Sayer and all those folks up in Seattle get just pasted, and we were pretty scared. And we've sort of kind of gone somewhat steadily. We haven't had a big, we're in the some days as low as 40, other days over 100.
What's your normal census?
No, I'm talking about the number of new cases.
Okay.
Yeah. In the state. So,
okay. I'm still trying to figure out where.
And where I work, the emergency department census is down 40%.
Yeah, we're almost cut in half. I understand it's starting to pick up, and we're starting to see a higher proportion of sick people. A lot of intubations going around, but I work once a week. Haven't intubated anybody in my EMS office or in the EOC.
You shouldn't. You shouldn't be. Terrible.
And I haven't intubated anybody in my office at home, which is where I spend most of my time when I'm not in the emergency department. Where do we go?
Well, I'm trying to get the screen to share, but it's giving me a hard time. I don't know. I don't know why it's doing that. So forget it. Forget it. Forget it. I tell you.
Yeah. So we don't really have an agenda, do we?
No. It's probably going to become pretty evident shortly.
No, I mean, there's always shit to talk about. The first thing we need to get into is what's in your cup. All right. So if you're joining us out there in the atmosphere, type in the chat, what do you got in your cup? I'll start first. I'm just doing Jack and Diet. Like, there's nothing fancy about it. I thought about doing some fancy bourbon or whatever. Yeah, I just wasn't feeling it. So I went to my usual. This is what I get when I'm on Delta. Like, this is my go-to.
Ritu, what's that girly drink you're drinking?
It is not a girly drink. It is not a girly drink. It is a vodka martini. I usually use Belvedere vodka.
Yeah.
But my new love in vodka is the Costco Kirkland vodka. Which
how are you getting that?
I got it at the Costco in the Couve, but like I don't know, a month ago before all this shit went down.
Yeah. Tony Henry's got a Bush latte.
A Bush latte. There you go.
Ed's rocking a Tito's and Club with a twist of lime. That's not bad.
Nice.
I see an Austrian East Sider there from Sturdivant.
Yeah. So
I'll tell you.
This is the vodka dirty martini, kind of extra dirty, extra olives.
Ginger says nothing wrong with a girly drink.
All right.
True that.
Well, I'm two-fisting it this morning.
All right. Well, what are you?
But I got a confession to make.
You have an Oregon, something fancy microbrew from Oregon?
No, this is sort of embarrassing, but we're just among friends here, right? Just the three of us.
Just the three of us so far.
All right, I'll show you what I'm drinking.
Heineken.
Huh.
That's fine. There's nothing wrong with that.
It's
the non-alcoholic version of Heineken.
Oh, why that?
And then my Aggie glass here. This is it's Topo Chico on the rocks with a slice of lime. I quit drinking. See, I had to tell them this beforehand because they would have booted me out.
You didn't tell us that.
No, I said I see. If I did, it's a happy hour. I would have, I was afraid I wouldn't be let in.
Well, you can come in and not drink.
You don't have to drink.
Group. It's all so good. You don't have to drink, but I'm drinking for many.
Oh, I appreciate that.
Yeah.
I appreciate that. With any luck, this will be a transient thing. But what I realized is working 12, 14 hours a day, I'd kind of like to get home and sleep. And if I drink a scotch or so, I don't sleep, go to sleep, wake up in the middle of the night. And I figured now is a good time for me to get some sleep. So
yeah, that's good.
So
yeah,
exactly.
I'm kind of jealous. I'm seeing all these good. Well, I don't know about the pomegranate juice.
I'm curious though, what is an unoaked Chardonnay? Because part of Chardonnay supposed to be kind of in oak?
Well, that's what makes it fancy. Hello.
I guess. I always think of Chardonnay as very oaky.
Yeah, I'm not a white wine guy.
Yeah, me either. I'm kind of a red wine guy.
Very often. So.
Yeah, I'll do a red. I like the red blends; those are super good. And there's not a bottle to be found anywhere near me, but if it's around, I'll try it.
I mean, y'all are from Oregon. You got the Willamette Valley there.
Yes, we do.
You almost have to go with the Pinot Noirs, right?
Yeah.
What's funny is we don't love Pinot Noir.
I do.
You don't?
No, we don't. So,
why?
Yeah,
weird.
I don't know.
Wow. What do we see here?
I don't like
Voodoo
IPAs
Ranger
either.
Oh, now that is a problem.
Yeah. So
yeah, let's see. I do see some Gompers gin tonic, little grapefruit, a mocktail.
Oh,
yeah, everybody.
Man.
I do. That's a good point.
Liquor stores.
Yeah, what's the status of your liquor stores in Texas there, Jarvis?
No. So that would be a really stupid idea.
They're usually next to each other.
Well, why separate them? I mean, get all of your needs.
This is what I'm saying about, like, at least in Oregon, right? And some of these other places that have these state controlled. I mean, they're not closing them, but they're doing curbside service, which they've never done before.
Well, I can see that, but seriously, everybody talks about closing liquor stores. Well, it's a sin, and you don't need to. unless you want to see people seizing all over the place, you need to keep that damn stuff going.
Yeah. No, I think you're absolutely right.
That is, I heard the Colorado governor shut down the liquor stores, and apparently some of his public health people went, wait, he did what? No. Let me tell you about withdrawal. And it lasted like 12 hours.
Did he shut down the weed stores too?
Yeah, the weed stores are open still. They'll do curbside delivery. You got to pull up and you can get it.
Here? You're talking about?
Yeah.
But I was talking about Colorado.
Oh, in Colorado. I'm sure it's the same there.
Yeah.
So Start Out There is talking about Tito's. Tito's has switched over to hand sanitizer. We were running short of it in Williamson County. Now, Tito's is a little bit to our south in Austin, but we had this awesome place that has coffee and beer, and they brew their own beer. It's called the I want to get this right, Red Horn. And they switched over and started making hand sanitizer for us. I was a little disappointed. I was expecting it to smell like hops. It just smells like hand sanitizer, but it does work.
That's kind of, yeah. It's not gonna. It's gonna smell like hand sanitizer.
So one of our somebody that Mike and I know. I don't know if you know him. I won't name him by name, but he is a government official in this state who is a physician and a medical director of the state. Was at work in his office at the state when his wife texted him that the governor is shutting down all the liquor stores. So he jumped into his car at 10 a.m. from work because he was working in a state office, ran to the closest liquor store, bought $400 worth of liquor, told everybody in the store that he works for the state, the governor's shutting down the liquor store, drove back to his office, got out his phone, texted his wife and said, well, wait a minute, was that an April Fool's joke? And she said, yes, it was. So he called me and said, if you need any vodka, I got lots.
Got it, huh?
Too much.
So I got nailed with, I usually don't get taken on April Fools. April Fools or April 1st was Wednesday, and that's my ER shift. So I normally work the 6A to 3P shift. That's just what I do, and I don't really pay attention. I know it's pretty damn sweet.
It's cute.
So I show up, and every once in a while, our medical director, Ross Tobelman, will put me on an 11 shift.
Right.
And, it shows up on my calendar, but, I'm not paying attention to the calendar. So I have often come in and missed the shift. So I come in that morning, I'm already tired. I haven't slept much. And I'm thinking, had to get up at 4:30. And I'm like, Tobelman, what the hell are you doing here? He said, I'm here for the 6 o'clock. You're doing the 11. And the entire ER had me for a good 10 minutes. They had taken all the calendars down, so I couldn't find the actual calendar. It was, it was a lot more funny when you were there.
Did he actually come in early just to get you like that?
No, he was actually the night guy. I was relieving him. We had a resident. The resident was in on it. It was a resident up until that point that I actually liked.
Yeah, not so much anymore.
Well, he did all my notes for the day. So, yeah, he's still on my
There you go.
My good side.
For as much as we don't have an agenda, I'm wondering, but there's like 50 people watching. It's not bad.
Outstanding.
Yeah.
Yeah. What are questions?
Yeah. What are you drinking? What do you guys want to talk about? We found out what you're drinking. We did have one thing we were going to talk about, whatever. We're pretty loosey-goosey on it, but do you guys have questions about stuff? It doesn't have to be a COVID-free zone. If you got a COVID question, turns out we got a couple of experts here. So yeah.
And Jarvis and I are on too.
Exactly.
Tune says, what are you guys doing to keep your hair so short? There's no barber shops open.
Well, take a look.
Oh man, you just got to shave that.
It turns out I didn't have to work hard.
Yeah, me neither. Turns out mine just kind of stays like this. Although even for me, it's a little long.
Got a little stubble there?
Yeah, it's a little long. It's definitely a little long. I'm not a big fan.
That was when shit went down, was when my barber called me and said, we got to cancel your shave and your haircut.
Yeah.
And then I had to shave too. I had to shave the beard. So
right. That kind of sucks.
My first
no.
Yes.
So here
I don't even know what the hell it is.
Let's tackle this one person at a time.
All right.
I'm gonna go first.
You go. All right.
So
I'm assuming everybody can see Rimley's question.
There's
here, right?
like four people who put Tiger King.
It's on here. It's on here. We're gonna talk about it. Tiger King right now.
I'm only
right now.
So wait, I'm only 3 episodes in.
All right. So
Pack.
This is really a thing.
it is really a
Fuck
thing.
yeah.
Yeah. So here's the thing. I made it through about 2 episodes. I was kind of multitasking and I scrapped it. Right. And then all of a sudden I'm doing some EMS education via Zoom. Actually, I came up with this little thing to do, and it was actually pretty cool. Maybe I can get it to pull up on here. I don't know how I would do it, but I could try just to kind of show you. Anyway, and everyone starts talking about Carol somebody and naming all these people, and I had no idea who it was. So yeah, that bitch Carol says Ed. True. So anyway, long story short, a few days goes by. I think it was yesterday. I'm like, all right, I'm gonna put my seatbelt on. We're gonna just sit here and we're gonna marathon this bitch. And
I thought Ritu fell back.
and I gotta tell you, so first of all, I was a big fan of making
He's
a murder.
going to choke on that olive.
I was a big fan of making a murderer, right?
Yeah, I
So
love making murder too.
So I like that. So this falls right into that, although it's a little bit different. Same kind of, I don't know.
It's a legitimate documentary. It's not, I mean, it's reality-ish, but the guy's actually trying to make a real thing.
Yes. And so that was the beauty. So there were people there initially to film a reality show, but what we are watching are the people filming the filming of the filmers doing the reality show. So you're getting to see all this weird background stuff. That was pretty cool. And I'll tell you, I finally made it through it. The first couple 3 are pretty draggy. You get into it a little bit more, 5, 6, 7. It's worth your time. That's my take on this.
All I know is even in the first 3 episodes,
Yeah.
especially the third one, you're just like, holy shit, these people. I mean, every time there's like something crazy that goes on, you're just like, oh my God, this is real. This isn't like, and it's not even like, it's not even a reality show in the sense that they weren't on a reality show. This like is shit that happened that they then went back and did the documentary about.
Yeah.
I mean, they all had their own little live gigs online and stuff, but yeah, no, it's pretty entertaining. I will say that. The other documentary that we really liked was McMillions.
Oh, I started watching that. I got about 5.
Oh, is that about the old McDonald's
Monopoly game?
Monopoly game. Yeah,
Yeah.
I remember playing that.
Yeah, and that so
When I
the
was in
game was
college.
rigged. And so this is all about the FBI and how they learned the game was rigged and how they figured it out. And it's really well done. And it's just another story where like every time they show somebody and they talk to them, you're like, holy shit.
Yeah.
You can't make this stuff up. And these characters are real people. Like one of the FBI dudes who they talk to the whole time is so fucking entertaining.
Yeah.
So, but I would definitely recommend McMillions. That was really good. Somebody, it looks like, who's managing the FlightBrideED? Is that you or is that Eric?
Oh, it's me. Why? What's up?
Oh, it just said McMillions.
Yeah. I was just typing it in for people.
So somebody's going to tell me about this whole tiger thing. So Amber says that apparently one of the Bronx Zoo tigers has COVID, and that's interesting.
Well,
I'm not sure.
But
Has anybody out here ever intubated a tiger?
I've seen it. They use like a garden hose or some giant tube about that big.
All I'm thinking is
you got to watch
wanna-
Tiger King to learn about that.
did they intubate a tiger on Tiger King?
I haven't got through the whole thing. I don't know.
They do use ketamine.
You know,
I think I'd want a lot of ketamine. How much? All of it.
Yeah, they probably use quite a bit.
Yeah.
All right, there's a few questions that are going on in here, and
All right, what do we got?
It's been a good hodgepodge. So let's do right here. We'll start with one. Will anyone be switching to the Dyson vent for their service?
Is that really a thing?
Yeah.
I heard there was going to be like a Tesla vent, and it's apparently just CPAP. So is the Tyson thing real?
I heard it was real. I don't know. It sounds like it.
Is it just a vacuum cleaner that you just plug into the?
No,
Turn on and off, on and off.
Yeah,
it's a real deal.
I guess I'm going to have to go. No, we're probably not going to switch. We did order a vent for every truck. Now we had this in our budget before, the COVID silliness. We were going to get the,
we're going to get the Hamilton or the Rebel.
No, we're buying 23 of them. We
The
couldn't afford that.
The Zoll one.
No, good Lord.
What's
Sturdivant? Help me out here, buddy. What are we getting?
Oh, Sturdivant. Yeah, I hope you're paying attention, buddy.
He'll tell me.
You just got called out.
Here, hopefully he's not talking about the vent we just bought. Anyway, it is for some reason we're not getting it real quick. Everything is getting backed up.
Yeah. Well, yeah. All right. So here's an actual question. Stand by. I got to go find it.
No, that's not as old.
Hands only CPR.
Yeah.
Yeah.
So what do you think about it?
So what do you think about hands only CPR to reduce airway exposure to first responders? Turns out it doesn't probably reduce it that much.
Yeah, no, because now I'm a big fan of hands only CPR until we get there
for lay people.
For lay people, yeah. But if you're trying to reduce airway exposure and you're thinking just because you're not, doing DL right up in their oropharynx, which was kind of a silly thing to do anyway, then if you think you're not doing that and you're not getting any exposure, every time you press in, the patient is essentially coughing. Yeah. So you're creating this storm of cooties. Even if you don't have anybody over the airway. So I'm not sure that would really help us out much.
Yeah, I agree. You probably have less exposure if you intubate them and put a filter over it.
Than I agree.
If you are doing hands-only CPR. So I agree. I guess one of the questions, though, this brings in cardiac arrest. And so I'd be curious, Jeff and we haven't talked. We talked probably a week or two ago, which feels like
a month ago.
It feels
I think I hit you up about testing.
Right? But so what are you doing PPE wise on cardiac arrest? Are you not assuming, but concerned that every cardiac arrest may be COVID? So you're full on for every cardiac arrest?
Yeah. So the thing I've been saying is all codes are COVID codes. Now that I don't actually think that's true, but we can't tell them apart. So we're going to treat them all the same way. We went through
from a staff protective situation.
Correct. Yeah. And so we went through a couple of interesting things. I feel so bad for my crews because shit is just changing so rapidly. And I was trying to keep up with it. And I think we just, so Daniel, by the way, is saying it's the Medtronic HT70. That's the vent we're getting. So I wanted to try to minimize the exposure. So we switched over to iGel. We're normally a VL intubation sort of shop,
because we can have this conversation. This is good.
Good.
Yeah,
so
I feel the tension rising already.
I'm just gonna. I don't know what Ritu's gonna say, but I'm just gonna say now, Ritu, you ignorant slut. Just because I wanted to. Yeah. So we switched to we switched to iGel. We switched to iGel thinking that there would be less exposure. And I'm just not entirely sure that that's true. So I think you change a little bit of exposure during the insertion to a lot more exposure across the length of the code because the iGel doesn't have a good enough seal. And then I got to thinking, guys, we haven't used DL for 8 years, and we're actually pretty good with VL. And we're using VL. We're using a hyperacute angled blade. So you're at arm's length when you're intubating anyway. So we just went back to that. We're working on a thing we're calling the Brandy bag. One of our medics is Brandy.
I saw you posted it.
Yeah, that's cool.
Yeah. So we're still trying to work out some snags, but hopefully we'll get it out there within the next day or so. So that's kind of what we're doing.
So we had a big conversation. So number one, we are assuming, basically saying any procedure that's aerosolizing requires full PPE, regardless of what your clinical worry is about the patient. Twofold.
And I'm assuming here you're all in on the CPRs and AGP.
Yes.
Oh yeah.
All in on that. Absolutely. So because we think that the combo of people who might be carrying it, and you're doing an aerosolizing procedure, and then people who are actually sick with it. So the downside there is, I think, getting into your PPE to get into the call, it creates a slight delay.
Yeah.
We had a long conversation, and we have some super smart doctors in our medical direction group and then me, but we had a long conversation about this whole what to do about the airway stuff. And started out, maybe we should go supraglottic. And then we heard from some of our folks in Seattle, and like I said, Andy McCoy had checked in. They had gone that route, and then they found that if they had found that there are just a lot of secretions, especially if you think it's COVID, and as a result, they went to a strategy of intubation first, because they felt it controlled the overall aerosolizing stuff better. So
yeah, and it's interesting because they're still doing DL too.
They are, I think, but so we do VL in our kind of all 3 counties. We have different VLs. 2 of them are Mac blades and are the McGrath, and then the other county is glide scope. The glide scope with the hyperangulated blade, we're using a rigid stylet called the S-Guide, which is a rigid bougie. It's a more rigid bougie, so you can still bougie it. And then in the counties,
I like it when you say bougie, like
bougie. And then in the counties that are using the McGrath, which is a traditional blade, most of the time they're using a regular bougie. So
it seems to me on this. Well, go ahead, Ritu, and then I'll.
This is one that I see a lot, like in the EMS medical directors group and things like that. I see a lot of conversation. People are proponents of doing the SGA because they want to minimize exposure, and I don't think you are. And I think the other problem is that if you transport that patient, and we had a question about that too.
Oh, we'll definitely get to that.
Yeah, if you transport that patient and you bring them to the emergency department, then you've got another potential exposure.
Right.
When you have to change out that SGA for an ET tube.
You're passing the buck.
Yeah.
And there's a good chance that you're intubating them out in the open. And, like we say, the solution to pollution is dilution. So if you're in an outside area, it's less concentrated cooties, and now you're passing off the buck to doing it inside. Yeah. So let's just because this has been my pet peeve all along, and I think I'm right, and now I'm going to be proven right. So, there are those people that say, you'll take my DL when you pry it away from my cold, dead fingers. Yeah. I don't hear them so much.
No,
I hear everybody asking where the VL is.
Actors right now.
Yeah, exactly. Quiet. Crickets, as they should be. But now we're going to do you want DL with a camera on it, like the regular CMAC and the McGrath, or do you go all in on the hyperacute? Well, I think this is the great time to go all in on a hyperacute, because if you have a McGrath or a CMAC with a regular CMAC blade, and you're using it just like you would normal DL, then what the hell's the benefit from a cootie control issue? That's the beauty of the hyperacute angled, because you don't get up close. Now, you can have some back off distant vision with the regular Mac version, but I still think you're a little further away with the hyperacute angles.
Yeah, I mean, like I said, I happen to have one county with glide scope using the hyperacute blade and another with the McGrath, and watching my crews, they're still farther away with the McGrath, and so
then what?
Then they would be with a regular DL.
Sure,
they're still back looking at the screen, and even though you can most of those cases you can see chords anyway, you're seeing a much better view of chords on the screen than you do if you're doing a DL.
So let me ask you this though, and I'm just throwing this out there. I feel like you're sort of like, if somebody, because there are a lot of places that don't have DL. Excuse me, VL.
Yeah.
That's just that's just the reality of it.
Right. We have one place in our county that doesn't.
Yeah, for sure. So I feel like if we're worried about long-term exposure, right? This continuously aerosol generating procedure in the sense of a iGel, for example. Even if all you had was DL, aren't you better off using DL for that short amount of time, getting that tube in, getting that cuff inflated, and then so you might have a little more exposure up front, but over the long term, you're probably going to be better off. Does that make sense?
So I think if you compare, first off, you have to assume that you're going to get it in on the first attempt. And if you're a system that is not routinely intubating patients, and then you're normally putting in supraglottics, and now you just get a DL thrown in your hand and say
Agreed.
intubate,
Totally different story.
you're going to suck at it.
Agreed.
So then you may as well just not ventilate at all. Another option, though, is just to stick with a BVM. So the catch, if you're going to do a BVM, is abandon all hope of getting a good seal with one person. Use two people.
Oh, absolutely.
Again, this is like a perfect opportunity to hit all of the things that I've been saying for a while anyway. So two-handed seal, if not for the patient, for you.
Lectures about this, I've heard.
Yeah,
I do. It's kind of a big deal. Do it, damn it.
I was waiting for someone to jump in there and bust the chops a little bit. Ritu was right on it. It's good. All right.
Yeah. So I think that this SGA DL VL question is not as straightforward. A lot of people I know are saying, "Oh, just do an SGA," and we had a long, vigorous discussion, and we came back with doing VL, and then we have a couple places in our system that don't have VL, and we still prefer they do a DL first if they can.
So I think the other thing you can't really have this conversation in isolation from what is the norm in that system.
Yeah,
so if the norm in that system is you're actually really good with DL, well, then make sure you have good PPE on, preferably a face shield, and get it done quickly and get out of the way. If you suck at intubation, period, then the difference in exposure, I don't know. I don't think it's going to be very good, because if you suck at it, you're likely to be down there quite a while. You're also likely to be interrupting compressions and doing other things. So when we went back to intubation, I said, don't interrupt compressions. Just do it like you normally do it.
I think that the side, Mo and I have talked to the folks at CARES about, I think we've already put in a paper, but I think our nationwide cardiac arrest survival is going to plummet. And even if you could exclude people that you knew were COVID, it's still going to plummet, because there's going to be less bystander CPR. There's going to be more delays in getting to the patient because everybody's got PPE on.
And I'll tell you that here's the real reason it's going to tank. Because the largest city in the nation is no longer transporting patients without ROSC, and people are just going to die left and right because of that. This is clearly
for the hospital where they can fix them.
Who had 33 minutes on their ticker before we hit that? Did I?
He asked it a while ago.
Yeah, right. It's 33 minutes. So before we get into this, because I want to, but let us know in the comments here in the chat, what is your PPE situation like at the place you work? So, like, do you see stuff? Like, what's going on? I've seen a lot of comments in there, people talking about like rain ponchos and rain gear and all this kind of stuff. So I'm interested to see what you guys are doing out there. But let's get back to let me hide this thing out the way here. Boom.
And I do want to hit on the PPE thing.
Oh, we're definitely going to hit on it, but that was a good segue into the. Oh, by the way, somebody said something. Oh, Natalie, Storm of Cuties is a great band name.
Wouldn't that be great? That would. Hey,
one?
Congratulations, Natalie, by the way.
Yeah. Soon to be
future doctor.
Hey, Natalie.
Future doctor. Exactly. It's awesome. All right. So let's get back to this thing right here. Boom. Is that it? No, that's aircraft. We'll come back to aircraft stuff. Oh, right here.
Oh my God, the apocalypse is upon us. What's the proof? The proof is that they're not transporting patients with ROSC.
Unless you get ROSC. That's fucking
without ROSC.
Crazy
without ROSC.
Shit.
Absolutely. I mean, all you have to do is turn the news on, and they're going to show you that this is how bad COVID is. That, oh my God, we're rationing care. We're leaving people dead in the streets.
So in the chat, if this is something you've been doing forever,
do you think because think about our listeners. Every one of our listeners is like, oh, for the love of God, welcome to the modern age. Is there anyone who is forced to transport corpses to the emergency department? Let's try it that way.
I think there are still states that there are still states where they have to transport. It's not many.
Yeah, that's the question though. Is there anyone out here who works in a place where you are mandated? I'm not asking you if you think it's a good idea. Are you mandated to transport all cardiac arrest? So I'm kind of curious.
Yeah, no, I think there are some places, but I'd be interested to hear.
Yeah.
That was an interesting take. I've had 2 cardiac arrests transported to me in the last week. One, maybe the crew didn't recognize they were an arrest until I got them.
What?
But the other one was a witnessed VF, and they kind of just felt like they needed to transport them. And
so were they still in VF by the time they left?
No, they were not. And
how'd they do?
They didn't do very well.
Interesting. You should publish something on that.
Badass emergency phisian and a PAPR taking care of them.
Despite that,
Bafford, right? But yes. Fucking ER doc.
Yeah. So I see Jaron Gerald says they transport everybody no matter what. I'm kind of curious where they're from.
Where are you from, Jaron? That's so sad.
So I think everybody recognizes our sarcasm here, and most of us recognize that if you're not getting pulses back in the field, with very, very few exceptions, persistent VFib, I get that's a different issue. If they die in the back of your truck, depending on your, well, now that's interesting. So, Bill, this is not what I hear in the news. I hear that the plague is upon us, and he's saying that they've been doing terminations for 40 years. So, is this not a change? I really am confused.
Maybe we are a victim of fake news.
Could be hashtag.
Now, never happened.
When I was working in Yonkers 30-something years ago, we were definitely transporting these people.
Yeah.
With horrible CPR. Myself, knee on the chest.
What has it been about 2 years ago now, Dr. Sahni?
Western North Carolina.
Oh, yeah. Nice. We instituted our cardiac arrest checklist, and not only are we not transporting people that need CPR, but once we get ROSC, we're not really even leaving for 10 or 15 minutes.
Right. Yeah.
Like,
the wake kind of 10-minute delay. You're not, you have to don't package the patient until you get ROSC. Because if you package the patient, then you're more, hey, is that, oh my God. Hey, Caleb.
What's that?
Caleb's doing me a solid
here.
Here.
Bring one over here, please.
There's not much.
The only problem is I'm the one that makes the martinis in my house, and I'm empty. Anyway, so what was I saying?
How's it going?
I don't know. You saw a comment there somewhere that you were
on the podcast. What was I saying?
I don't remember.
I have no idea.
No fucking idea. A couple years ago, we instituted the checklist. We do the wake 10-minute. After you get ROSC, you wait at least 10 minutes till I'm wearing a Timbers hat and a University of British Columbia shirt. So
yeah, it's okay.
Sorry for one of the few times I'm not wearing a Michigan item. We try not to transport. And what's interesting is, I like, oh, my parents are calling me. Oh, well, hopefully everything's okay. But
yeah, hopefully it is.
A comment from Kendra. At one of my former jobs, we were able to call field codes until we got a Lucas. Since then, we were mandated to transport. And one of my fears with mechanical CPR is that if you implement mechanical CPR without a specific intent, then you end up with more transports of dead people. And as a result, you end up with more transports of people who could infect other people. Although I still think that's small.
Yeah.
And you always end up, you don't transport these working arrests code 1. So you're driving code 3. How many of your medics are strapped in the back during a code 3 cardiac arrest? None of them. And so you're increasing risk for no outcome. So that's, I think, one of the downsides to Lucas. And we have Lucas in various parts of our system. I like it when you want to transport somebody, but I'm a real believer that the only reason you transport somebody is if the juice is worth the squeeze. Rather, if you have something on the other end of that transport that, and to me, like PE, that's maybe somebody you would transport, or if you have an aggressive cardiologist that's gonna take
on the table
DF to the cath lab regardless, or ECMO, or those sorts of things.
So I saw Daniel talking about, and I want to come back to Lucas because we're doing something a little different with Lucas. I want to, Daniel said, well, what about ECMO? I'm like, well, yeah, what about ECMO? Because we ain't got it anywhere.
Yeah.
Sure, there are some hospitals that we have that do ECMO, but they ain't going to do it for our cardiac arrest patients. So I think we hear a lot about ECMO because it's the sexy thing. And if we just transport all of our people, they will magically start getting ECMO.
Yeah.
That just ain't going to happen. That is not reality. That needs to be a very tightly organized team, and it needs to be something that they are all in on, and the hospital has agreed on what criteria they're looking for. And among those criteria, then they will commit to putting those patients on ECMO. And that's just not we always talk about Minneapolis. Well, sure, but that's not the reality in most places.
Yeah.
So,
I mean, Albuquerque does field ECMO, but then, I'll
twice.
be honest, I've heard, what'd you say?
He said twice.
I think it's more now. It was twice in January it was 3 times already by January. They were 0 for 3, mind you, but it was 3 times when
I mean, more power to them.
Yeah.
Go for it. But I think we clearly need to understand that needs to be looked at it as an investigative process.
Yeah.
I don't think it's ready for prime time, and I don't think they would tell you it's ready for prime time.
We have one center in Portland,
unless of course you have the head up.
Yeah.
That's a whole nother thing.
Yeah, we have one center in Portland that's doing ECMO, although I think they've turned off their ECMO during the COVID, even though we don't have many cases. And that's an interesting there's some interesting ethical issues I'm seeing popping up with services being unavailable and things like that. But we have one place in Portland that does ECMO. Where Mike and I are, we don't have time. We can't get there in time. So ECMO is not really. And none of my cardiology places are willing to sort of commit to taking a witness VF to the cath lab, even if they're still under compression. So I have some Lucas devices in my system. Actually, the fire department that I've been involved with the longest got them a while ago, but I had an opportunity to get them. So, so.
All right, let's jump into.
Let me talk about the Lucas device.
Oh yeah.
So I've been very skeptical about the Lucas device because I think it distracts you from doing the things that are important to get the patient back. So we had a very specific process for implementing the Lucas. So you could, it was a 2-step process, and I think Mike Levy described it really well in his PEC paper. So we adopted that, but we don't let them begin that process until 10 minutes in. And until the patient is already intubated. And the reason we do that is the Lucas is really good at generating blood and puke, which makes the intubation harder. But we were shooting a video of how to use the brandy bag, and I didn't want to be the one doing the bag or the intubation because I wanted my medics to do that. So I'm figuring I'll do compressions. I'm sitting there doing compressions with an N95 mask, and that shit sucks. I thought I was going to pass out. It is hard enough to do good CPR, but slap an N95 mask and a whole bunch of other stuff, it's just exhausting for the crews, way more than normal CPR is. And if you're going to do good manual CPR for 10 minutes, you have to have lots of people swapping in and out. And now you're increasing the potential exposure and the chance of our gowns ripping and exposing. So now, as long as we've done the main things that we need to do, shock them if they need shocking, intubate them, I'm saying you can go ahead and still do the 2-phase approach to the Lucas, but you can do it earlier during this COVID issue.
Yeah.
Hey, Carol, I saw your comment that they're still doing ECMO, but I'm hearing that they may not want to do the peri-arrest ECMO or the in-cardiac arrest ECMO. But I do, I've heard that they're doing the standard ECMO stuff. Yeah, I mean, I think the Lucas plays a lot of roles. I have one of the folks I work with is a firm believer that the Lucas saves paramedic backs, and again, I think the key is with any mechanical CPR, you don't throw it out there and go, here you go, run with it. That you have a plan. Why do we use it? What is the benefit? Why are we implementing this tool? And how do we implement this tool in a way? I think I'm sure Ginger can comment, but I know that Mark Escott in Austin had, they actually took them off when they found that the performance seemed to be worse.
The survival dropped with them.
Yeah.
And I think the reason, and they did that, the way they did it wasn't exactly planned, but it wasn't exactly helter-skelter. They actually had trained on it. And I think if we're honest, the vast majority of places you get a Lucas, their entire training is whatever physio tells them. They just throw that thing on the truck and say, here, it's a miracle worker.
It's the life-saving machine.
Correct. And
there's no feedback like, hey, it took you 2 minutes to get this Lucas on without compressions. That's worthless.
Yeah.
I mean, I'm pretty proud of my fire department. One of my fire department, the one that carries Lucas, they, looked at Mike Levy's stuff, and when they do it, if I look at the CPR process, the only way I can tell that they put the Lucas on is the compressions go from kind of all over to 100 per minute. But they're doing steps at the regular pauses and not having large 20, 30, 40 second pauses. So that's good.
Yeah.
Yep.
Let's get to the PPE situation. A lot of questions. A lot of questions out there about that. And for some reason, this thing will not let me zoom. Zoom is not the right word. I have Zoom on my brain.
Zoom.
Yeah. Zoom.
I don't even need
one last thing though on the cardiac arrest piece, because Andy McCoy was on here, and Seattle did a nice. They did a podcast with NEMSP with the PEC podcast, and then Michael Sayer and Tom Ray did a webinar with NEMSP. If you
that was great.
.org, you can take a look at that. But most cardiac arrests in Seattle, where if you fall asleep and they wake you up, they count that as a save. But did I say that? But even they're a pretty high COVID place with a lot of deaths, and they said that most cardiac arrests by far are not COVID related.
Yeah.
Don't let there be secondary casualties because you're so worried about COVID that you can't take care of your do the regular things. And unfortunately, I think we've already gone there nationwide.
Yeah, I do too.
Yeah, but then what? So what about the? I know you didn't say this, but this is how I interpreted what you say. Is that, cardiac arrests rarely have anything to do with COVID. Blah blah blah, whatever. So I totally get that. But all it takes is that one. Right now we've got a whole. We got 8 people that are going to be, doing self-monitoring and all this crap, because what ends up happening is,
there's something to talk about.
They're not wearing the correct PPE for that particular call. But what happens but here's an even better one.
Yeah.
Somebody calls in, and I may have carnal knowledge of this next possible scenario.
Carnal knowledge?
What's that?
Is that what he meant to say?
I don't think that's what you meant to say.
No.
I sure hope that's what he meant to say.
No,
let's hear this one.
It's not what I meant to say, but I know about the situation. So it's just a call for a patient that doesn't feel very well. They send in the surveillance, the scout, whatever you want to call it, the one person in PPE. And they start talking to the guy. Yeah, I've been feeling like shit for a couple of days, whatever. And then he proceeds to go into cardiac arrest a minute after that one person goes in there. And then what has happened is that people end up not in full PPE because they feel like they need to go in there and like immediately take over this person. And that is a dangerous game to play.
Absolutely. I think finding the happy medium. And so we're having people say things like, well, maybe because even in a really good system, most of our cardiac arrests don't survive, we should just stop doing them. And I'm like, oh my God, no. And then I'm having people say, well, maybe we should stop doing asystole. I'm like, why is that different today than it was yesterday?
Agree.
It's not right now. Now,
Right.
in a resource poor environment where we are using altered standards of care because we are overwhelmed, that's a different question. But we're not there now where we are, and we're hoping that we won't get there. Do you have to? Is the fact that you have to be in full PPE going to change survival? I think it will, because I think
Sure.
I think that I want our providers in full PPE on every cardiac arrest, and if it adds a minute or two, it adds a minute or two. But changing who you work on because of this,
Agreed,
is an unintended consequences that unless you are there are places where that don't have a lot of COVID where their cardiologists aren't cathing STEMIs. I think that's wrong. In my shop,
ours are right there with you.
Yeah, I mean, in my shop, our cardiologists are at least asking questions like, what is your concern about STEMI, blah blah, or about COVID? I think that's reasonable, but they're not blanket saying we've stopped doing primary angioplasty.
Yeah.
And
ours are switching to, now this is for the COVID.
I have a problem with that.
Well, so for the COVID patients, so they're screening. If there's no risk, then they do it just like they normally would. They'll go in and cath them. If they screen positive for COVID, what they're doing is TPA, and then
but that
failed that
too. But I mean, I think there are places where the cardiologists have said,
I'm sure
every STEMI is just going to get TNK. Period.
So see, it would be interesting to see how long that lasts once they realize the downstream impact that's going to have on them.
I'd be curious to see. Amber started off some a comment about dispatch and asking pre-screening questions, things like that. At least in our area, we've moved to protocol 36. We are at level 0 with that. For those of you that don't know that is IAMD. IAED. God dang. Thank you.
International Academies of
exactly.
Medical. There you go.
Exactly.
International Academy of Emergency Dispatch.
Thank you for crying out loud. Thank you. Thank you for correcting me. Anyway.
Thank you very much.
So we're screening every caller for a medical problem through protocol 36. And what she's saying is that they are seeing people that are like not telling the truth. I know that's probably hard to believe.
Yeah, shocking.
Are you guys? Ritu, I sort of know well, maybe I don't, but I'm curious, Jeff, what are you guys screening people? What's going on? And
we're doing it. Yeah, we're doing it the same way. And then even if they don't get 36th, after we have given all the instructions and got the unit en route, we then ask, is anyone in the house?
Yeah.
Have you running a fever, a cough, or have you tested positive? If you have, please move to another room and have the sick dude, if they're able to, walk out front and meet us.
Yeah.
So yeah, we do. One other thing though, when we're going back to the all codes or COVID codes, though we're recognized that the majority. What's that?
You're doing a go back.
I'm doing a go back. So the one of my former paramedics is a third-year EM resident in the Bronx right now. And she's just telling me what a jungle it is. And she said that her message on this is that everybody has COVID, everybody in the hospital. She's seeing a patient because the normal routine emergencies are still coming in. Patient comes in with kidney stones, classic description, she says. She does the scan, and, the scan has to get up into the inferior lungs to get all the kidneys. Exactly. Yeah. So congratulations, your kidney stone with no COVID symptoms has frickin' COVID.
Yeah.
So, and when you combine that with this concept of 3 days worth of asymptomatic exposure and transmission, there's a pretty good chance there that if you're in a place like New York or New Orleans, where you have a really high, prevalence, then maybe your codes are going to be more COVID-ish. I still think, though, that you have to give them the benefit of the doubt. Now, when you get there, start CPR, and as you're getting with full PPE,
that's a big one.
And if you get a history that said, oh, by the way, they were tested, we know they have COVID, and they're in a systole, then no need to drag this out. We know what the mortality is of COVID once you're intubated. These are people that we know have COVID. Once they get intubated, they're not really surviving very well. Okay, well, this is one step beyond that. Now they're in cardiac arrest. So if you get there, they had COVID and they're in a systole, then on those, I'm willing to terminate sooner. So I did, I'm having my medics now call me way early with any time before any advanced airway, call me unless it's an airway protection on trauma. And then for cardiac arrest, call me and let's work through this thing together.
Yeah.
If it sounds like your regular cardiac arrest, 40 minutes, baby, all in, let's go, just like we normally do. But if they have fever and, pneumonia symptoms, then and it's looking bad, I'm probably going to terminate that pretty early. We're 40-minute resuscitation people here. I terminated 1 in 5 the other day and 13 a few days ago.
So they have to call you for every termination?
Yeah, I've done every termination for a long time.
Well, yeah, they don't have to for us. They can just...
Who do they just terminate on their own?
Mm-hmm.
Yeah, so I think that's a state issue. So the way that we've read this, and I know there are people in Texas that disagree with me, but the way I read it, it has to be a physician, and I'm not going to pawn that off to the ER. The primary reason I'm not is they're going to say something stupid like
transport.
I don't feel right, exactly. Yeah.
Weird.
So I do. That's the reason I do all of my own.
No, we don't. If they're asystole, they don't need to call anybody. They can just terminate. It's nice.
Is there anyone there doing, Jeff, in Texas that you've heard of doing sort of telemedicine stuff with people on scene?
Yeah. So speaking, I see memes out there. We're doing Pulsera. I had one today. I woke up yesterday. So I have it set to do a siren. Well, I've never had a siren ringtone before, and I'm laying in bed, just out cold, deep REM sleep, trying to figure out why the hell this siren on the ambulance driving past my house is just parked in my front door. And then it occurs to me that it's Pulsera, and they want to video chat me. And then it occurs to me that I'm out cold in bed, and the video on that is going to change the situation a little bit. So I stumble and fall out of bed and get somewhere where I can turn the thing on.
Yeah.
But it's helping. I'm seeing, I saw a guy that we knew had COVID, got sent home. And so the story is he had a syncopal episode and, looks okay, but his blood pressure is a little bit low and his oxygen's a little bit low. But so then I got a picture of him and he's laying flat out in the middle of the bedroom. And his blood pressure really is.
Is he prone?
Yeah, just
good.
No, no, that'd be good. I think I'm going to syncopize, but I want to recruit those posterior alveoli. I'm just going to go ahead and
go prone. I mean, why not?
Yeah,
right.
Well, the picture though really gave me some additional information. It helped me.
And so, have you always used Pulsera, or is this something you guys instituted, sort of, with this whole thing, or what?
Yeah, no, we're doing it right now. I've wanted to do it for a while, but their business model is that the EMS agency doesn't pay for it.
For sure.
The hospitals pay for it, and I'm not in charge of hospitals.
Right.
So I don't really get to be the decision maker. Right now, during this COVID thing, they're basically giving it away for free. Now they're limited which modules you're using, but they did this workaround for a general channel, not STEMI, trauma, stroke, anything like that. And that's what we're using. And all 3 of our big hospitals have signed up. And now they're figuring out, hey, this seems to be useful. I'm definitely finding it useful. And I would not be surprised at all if they're like, oh, wow, this does some cool stuff. Why don't we just go ahead and keep this and use it for STEMI, stroke, trauma, sepsis?
Yeah, we've talked about that. I think might be an opportunity to talk about it again, Brandon. But wait, Remley's like, but what about ESO track?
Yeah, for sure.
Yeah. So there's so does Pulsera, and Brandon and I talked a little bit about their telemedicine sort of linkage thing. Is that through Pulsera that tool is?
So
to be able to talk to them?
Yeah, we're doing it. So there are 2 things, both of which it sounds
Brandon's going to text me again like any second.
And say,
let's see if he wants to jump on. I don't know.
Shut this Jarvis guy up, because he is so putting some fake news out there. So I think they have basically engineered this thing really, really rapidly in the last 3 weeks. So one, just the normal app is allowing me to make video contact with my medics and do telemedicine with them. The other issue that they pushed out just, I think last week, the update went out, is they have the ability to, you call 911. Here I am in the ambulance. Yeah. I'm going to your scene, and I'm going to try to get some information from you. CAD sends me your text message or text number, phone number, and I send you a text with a link to the Pulsera patient app. They click on that, and it downloads and installs the app. It enables you to create a video link between you and the patient on their device while you're still responding. And that way you can do a better job of your primary and secondary assessments for COVID. We're also thinking about doing that in the emergency department. You check in to see at the registration clerk, and they have the big glass cootie catcher there. And they just say, push the information under what's your emergency? Well, I got a cough and a fever, and okay. So here, give me your phone number. And if you have a mobile device, the doctor will talk to you and, kind of screen from there.
Yeah, we're doing, we had our tent set up, and we haven't really used it much, but we have rolling iPads in our department now. And so for somebody, we have a thing called SDC, special droplet and contact precaution. So if anybody is a potential COVID patient, which is like half the patients, even in a place like ours, they put them on special droplets. And what we're doing on some of those patients is I'm either calling them on their own phone, but now we're wheeling in an iPad. And then in the back, I've got on my computer, I can do it from my phone actually, but the iPad has Zoom on it. And then we have the computer in the back has Zoom. And I just go back into this back office with my scribe and call them on Zoom, and I can see them and look at them. And scribe hears the whole HPI and puts it in. So we're doing telemedicine within the emergency department. And then when I actually have to examine these patients, I'm in and out in like just a couple minutes with full PPE. So I feel pretty safe and pretty comfortable. And it's kind of nice because you make visible contact with these patients and they're all understanding. They're like, yeah, no, I don't even want to be here.
Yep.
So
we're doing that right now with the Teams app. So we have, instead of a tent, we took over the ambulance bay entrance. So we put big pylons up. So EMS just doesn't back up as far, and we have room for 4 or 5, 6 different seats sitting out there. And it's Texas, so it's not like it's bitterly cold. And they sit there, 10 feet apart, and we have whoever the nurse that draws the short straw, and they just spend the 4 hours all PP'd up, going from taking vital signs patient to patient. And we can do blood work out there and chest x-rays, but we try not to. And it's interesting talking to them on Teams. One thing, we have kind of a older population. We're a geriatric center of excellence. And apparently the use of the iPad camera is not a skill set in my patient population. So I'm like, sir, turn it over. Okay. Can you point towards your, no, sir, that's not your face. Down, sir, down a little. Okay. To the right.
That's classic.
Do you not have grandchildren? How do you not get this?
Ours are like mounted on little carts. But what's funny is we had them on little stands that are on wheels. So we just push them around. But what's funny is all our we had them out in the tent, and apparently all the chargers for them got stolen.
Oh, that is
really
classic.
Yeah,
that was lame.
I know, it's lame.
That shit doesn't happen in Texas. We're honest down here.
Bullshit.
No, we are. It's easy to be honest when you're pretty sure everybody that you're thinking about stealing from is armed.
Well, I guess.
Well, we're waiting for Brandon's going to jump on here in just a sec, but let's talk about the PPE situation here. So what's going on? How are you guys doing in your neck of the woods there, Dr. Jarvis?
So we are actually doing pretty well in terms of masks. We got a shipment of, I don't know, several thousand N95s. We have lots of surgical masks. Obviously, we have lots of gloves, lots of eye protection. The thing that we are having a challenge with is gowns. Gowns, Tyvek suits, that's in short supply.
Yeah.
So that's kind of where we are. I have heard we're not having people reuse their PPE. In my hospital, I have one N95 mask and one surgical mask that are currently sitting in a paper bag in our decon room, eagerly awaiting my arrival. So we're, I think that we are probably better suited than the hospital is right now. Now the hospital, there you go, Brandon.
Brandon. Hey, buddy.
The problem with the hospital is
sponsorship opportunity, by the way.
Yeah. Well, I'm not sure what there is left for you to do because we were plugging it pretty good.
Now we got to pull in like Remley to talk about ESO track.
There you go.
So we're gonna get the rest of them.
No, but continue, Jeff. So if you go, if you have crews that use an N95, maybe they just do their 6-foot eval from the doorway, whatever. They're not reusing that.
So no, we don't require them to. So the particularly like surgical mask, a lot of them are just using the same surgical mask throughout the day, but that's not really a requirement.
So after they're using a new N95 on every patient.
I think so.
Yeah.
Now we're not actually requiring N95s on all patients. We're requiring them on what we call PPE alerts, and you get hit on a PPE alert for dispatch using their protocol 36, or if they've determined even if they fell out of 36 and end up with a fever, they'll use that. And then for all cardiac arrest and now all respiratory issues.
Yeah.
So if you're an 80-year-old woman who doesn't have a fever, doesn't have a cough, who had a gravitational incident, went to the ground, and now has a broken hip.
Those, did we?
Yeah, well.
Yeah. So
then they only need a surgical mask.
Yeah.
Gown and no gown.
So we're doing the scout model. So first on scene, whether it's a fire, first responder, which in our system is all ALS, or almost all ALS, or the ambulance, whoever's there first sends in one person. That person is wearing an N95, gloves, eye protection, and then they're but they're still trying to stay 6 feet away. They're sussing out the situation. We're requiring our crews to place a mask on every patient, regardless of complaint, and minimum of a surgical mask on every call. But what a lot of our folks are doing is they're in most of our places they're getting it one N95 per shift. So most of them are just kind of putting it on and keeping it on during the shift.
Yeah.
But we're not burning through gowns so much because because of the scout thing. And then if the scout kind of finds that it's somebody who doesn't need a lot of workers, kind of a low acuity call, they may only send in one other person with PPE and to with the surgical mask to help move them to the ambulance for transport.
All right.
We're trying to minimize exposure, but we got Brandon here now.
I know. Thanks for jumping on, buddy.
Hey man, I'm always late to the party. And
you just weren't invited.
About Pulsera, right? That's why I came along.
Yeah.
Well, so I think the first thing is I got to tell you that is an outstanding looking jacket.
I had a feeling you would enjoy that.
Damn straight.
Yeah, I got the matching underwear too, but I'll just spare you guys. And
so see, I got my little
yeah.
glass there. So you got to hit the important stuff. What you drinking?
A little scotch, Macallan 12.
Nice.
Nobody
Very
liked
good.
Martini.
Oh yeah, Ritusa's gone. Right.
It's defective.
Yeah, you're stupid.
I'm drinking my Topo Chico with a slice of lime.
I'll drink for both of us, Jeff.
I appreciate that, man. And what you're drinking sounds awfully good.
Yeah.
So tell us about Pulsera.
Yeah, man. Well, it's you get most
in the age of COVID.
Yeah. Well, the biggest thing is we've been around for a while, but kind of the focus right now, obviously, is helping organizations, EMS, hospital systems, regions of care, one, mitigate the surge, and two, reduce exposure to clinicians. Because we get this, this baseline, even if our call volume is normal and half our clinicians are on isolation or on quarantine, then that becomes a surge. So just trying to find ways that we can contribute and help you guys out there on the front lines, really avoid unnecessary exposure. And it sounds like there are plenty of ways to do it. It's just one tool in the belt, that you guys are using. But I think the newest thing is the patient-facing app, which we've never done before. We kind of spun that up, and I think that's what you guys are using down Williamson County, right?
We're just starting to, it's pretty cool.
Oh yeah, that's what we were working through the technical aspects of that the other day on FaceTime. So
you got to give Rakesh or Ritu a text with the link.
Oh yeah, I should do that. Let me see if
do the live demo, man.
On the spot. Let me see if I can spin one up.
But by the way, I've been getting all these text messages from another thread of mine with the board of directors of the Texas chapter of NAMSP. And hopefully I'm getting them to hop on and give us some snide comments. So Dr. Abraham and Vitellani and Cameron and the good Dr. Pickett is calling. So y'all talk amongst yourselves, and let me see what crisis is befalling us in Central Texas.
All right. What is Brandon's conflict of interest? I mean, we've been very clear that Brandon.
Yeah. Oh yeah. Well, first of all, this is all free. I'm not trying to sell you anything. We're giving this away for.
Come on now.
For the price. It really is. It's all free.
And I think these ideas, we're getting much more creative about telemedicine. I mean, that's really cool. I think hospital communications. Have you guys created like a COVID screen for the electronic push? Like some of our hospitals want on every call, on every transport coming to the hospital, they want some COVID questions answered. Mm-hmm. Is that something you've built in now to the push to those systems that are using Pulsara for all their communications?
Yeah. We got a couple different regions that have. That's the thing, you can't hard code something like that in because everyone has a different screening tool. It's like using, sort of like stroke scores. We do have a few of those. We don't have the PIS in there, but we do.
Portland International Stroke Scale.
Yeah, the Portland International Stroke Scale. I voted that it get in there, but it just hasn't made it yet.
Mm-hmm.
But yeah, we have some of those in there that a lot of regions are using it, and they're it's just a standardized 3-4 question screening tool. And if they meet those criteria, then obviously they'll do an alternate destination or treat in place and monitor, every few hours. And that's why that's where we're using the patient app. It sends them a text, they download the app, and then they can connect via secure video to a medical director or a paramedic.
Yeah. So I know there are places that are using Pulsara for all hospital communication. And what we're hearing from hospitals is they want, like, on every patient, if this is a patient who stubbed their toe, they still want the patient has yes, no fever, yes, no cough. So have you built that into the push to the hospital on coming in as like a standard?
Yep. And it's a customizable field. It goes in it's a secure text, and it's just however many questions they want. Those are customized per whatever your needs are. But it's a single button push, and they can answer, they can go down the line and say, yes, no, do they meet these criteria? And then use those to assemble the right team, I guess, to route the patient to the right destination.
That's good. So did you guys start, as you were kind of farting around there, trying to see if we could spin something up like on the spot with absolutely zero notice, by the way, thanks for jumping on. So did your customers come to you and ask you like, hey, we're like sort of merging into crisis mode here. What can you do for us? Or were you guys sort of working on this thing and then made a push to get it out to people? Or how did that come about? Because it seems that would be crazy to just turn something on.
And usually, in the tech world, any tech company you've ever worked with, you can't just create something and have it out the next day. Yeah. Especially with healthcare, because then you have regulations. It's got to be HIPAA compliant. It's got to be secure. Then it has to go through Apple and Android and go through all their vetting, right? But really, how it happened is, as you may or may not know, Tyler, We, as you may or may not know, we've got we're working in Seattle with all the hospitals there, right? And we have been for a while.
Right.
And they were the ones that kind of got the brunt of it up front. And we got really lucky, and it was a hospital we had just implemented and trained, and so they were up and running on Pulsera for other things, stroke and STEMI, and then they got hit really hard and reached out to us and said, "Is there something we can do to reduce exposure? We're blowing through PPE like crazy. We've got a lot of nurses and physicians on isolation, and we need an answer." And so we kind of just jumped in. It was over a weekend, and built some special teams for them, some respiratory isolation teams. So they were able to do a lot of their assessments remotely using the video component. And then they've got obviously the team building and learning around that. And that's what kind of kicked it off. And then, at that moment we said, everyone else is about to need this. We're going to have these rolling epicenters. Then it was New York, and now Detroit's getting hit hard, and it's going to be coming to Portland, right? And so we've got these rolling epicenters that over the next few weeks. Okay, Portland, not Lake Oswego or Clackamas or anywhere else, just in Portland. So, yeah,
they're going to keep it out because they're building a wall all the way around Portland.
That's what I heard. I didn't know. I didn't want to bring it up.
But it's a wall that keeps gluten out. It's a gluten.
That one's been there a while. Yeah.
And GMOs.
And gluten.
Except Labradoodles.
So that was what kicked it off. And then we kind of just said, you know what? Everyone's about to be struggling, including a lot of us that still work clinically. And, when we're doing our other jobs or per diem stuff, everyone's going to struggle with this. And so that's when we just made the decision, you know what? As long as this pandemic lasts, the whole platform is, as long as it's used for COVID management, we're just going to give it away. There's not a lot we can do right now. We can't go in there in the front lines and say, hey, here's a
not making a lot of sales calls, are you?
What'd you say?
Not making a lot of sales calls.
No, not a lot of sales calls. Yeah. So we're just trying to, do our part and help out where we can. It's not, it's not a lot in some areas, but any little bit helps. So I don't want to go on a sales pitch. Anybody that knows me knows how to get in touch with me. It's just one of many tools, right?
For sure. Yeah. How's things at North Texas Regional EMS? Are you crews holding up? You guys, what are you guys seeing out there as far as COVID?
Yeah, we're starting to get more and more in North Texas. Right now, all volume is down like everywhere else a little bit.
Yeah.
Overall volume, and so it's hard to. You have to know what's coming because right now it's just really easy to relax and say, "Oh, call volume's down. This is nothing. This is not a big deal, right?"
Right.
But we know what's coming in the next few weeks, so we're prepping and trying to make sure that we've got systems in place, alternative staffing models if one day, half of our staff is exposed and we have to, we've got some alternate models. Our leadership team's done a really good job at prepping for that, working with our medical directors and some of our colleagues.
Nice.
Well, let me, so number one, just, I was in the middle of doing some shout outs to our Texas chapter board when Pickett called. And so let me tell you, this is the fun thing when stuff is just changing so incredibly fast on a day-to-day basis, is rumors just get out of control. So Pickett calls me, and obviously he's with Austin Travis County EMS. They're our southern neighbor. And he says, so maybe just help me with a little rumor control. I hear y'all are not doing CPR on anybody, no compressions at all until you intubate. And then you're just calling all of these codes, and that you're only doing MDIs and you're not doing NEBs. Okay, well, I guess maybe some of that's true. We were not doing NEBs. We couldn't afford MDIs, so we did terbutaline. And no, we're still working cardiac arrest. We're just, we are intubating earlier, but no, we start compressions quickly. So it's amazing how in this era where we really are changing rapidly, rumors can get out of control, and trying to keep everybody on point, on message is such a challenge. I'm doing clinical videos like every day, every other day, trying to get messages out.
Yeah.
And, you run this balance between getting lots of information out and overwhelming people with information.
Right. Well, and that's the thing. I mean, we haven't put out a clinical guidance. Well, we put out new protocols like this week. We put out the county clinical, my clinical updates in terms of guidance around PPE. I haven't done a new one in a couple of weeks, and I'm pretty comfortable with where we're at right now anyway. So that's pretty good. But we were hitting them with new stuff every few days. And it takes a few months for a protocol change to sort of get integrated, if not a year. And we're doing new stuff every 5 minutes. The other thing that I'm thinking, so in my 2 counties, I have direct oversight over 4 agencies, but there are 16 different agencies involved. 18. There's 7 fire departments in one and 9 in the other county and 2 ambulance agencies. And as a result, because everybody buys all their crap from different places and everybody's PPE looks a little bit different. But one thing that happens,
it's a rainbow. It's a PPE rainbow.
Yes, it's a rainbow. But what happens, one agency can't get any gowns, so now they're in Tyvek. And it rains through wildfire. Why aren't we in Tyvek and the rest of the county?
Because you don't care about your people. That's why.
I don't. Yeah, I've had
you heartless bastard.
I've had that kind of shit happen, and it's been very sad and made me sad when that happens. But
yeah,
Ritu, how many people photoshopped that picture of you in your full PPE there? I saw about 80 different versions.
No, I think it was only a few. Yours was the best though with the guitar. I liked that. That.
It was good.
Mike's with the "I hate Ohio State" signage. That was a good one.
Yeah,
good. Yeah,
good.
You sure that was photoshopped?
No, it was directly straight from my heart.
There was a fish. There was a guitar. There was a couple guitars.
Yeah, the fish was a good one too.
There were some good ones. All right, listen, we have gone pretty long.
Yeah, I think this was good.
What are the odds that would happen?
With no agenda.
That's true.
Exactly.
I knew finding content, excuse me, wasn't going to be a problem. I knew that because of our people. They jump in and they got questions and they've got comments. This guy's like,
we got good people.
Brian's like, I want you to keep.
We love Brian.
Yeah.
Oh, Remley, stop. Stop.
All right. Any final things? And again,
Ohio State thing, Jeff.
I figured that. Yes.
Yeah.
That's all right. So let's start with Ritu. Final thoughts, buddy.
Keep calm, carry on. It's, you just do the best you can with what you've got. There's no emergency in a pandemic, so make sure that your people are wearing their PPE before they go in. But I'm really proud to be in EMS right now, and I'm really sorry for what the folks in Seattle and New Orleans and New York have all been through. But I'm very proud to be part of this group that is really valiantly trying to fight this fight.
Yeah, agreed. Dr. Jarvis?
Oh, it is hard. I get that. The amount of information coming out right now, trying to stay on top of it, what we are supposed to be doing for hypoxic respiratory failure. Are we supposed to be shaking them upside down? What do we do? The science on this, what little there is, I mean, primarily we're dealing with anecdata because that's all we can do right now, is changing really rapidly. And it is very, very hard to stay up on it. And messages are changing. I mean, just the CDC went from don't wear masks to wear masks. And I think they had, thank you, Ritu. I think they did it with a good reason. But things change, and people who think that we live in a black and white world where medicine, there is a right answer and there's a wrong or right answer, are going to be very frustrated by this. And that's a natural thing. On the other hand, we don't really have a choice. We have to respond and adapt to changing circumstances and use the best information we have. So I think the best thing we can do is just have a little patience with everybody we interact with. When you show up at the ER and you get yelled at because you're using oxygen or you're not using oxygen, or you're giving an ebb or you're not giving an ebb, or whatever the hell was going on in that hospital 2 hours ago and has now changed, just have a little patience with him, because everybody is on edge. Everybody is getting beat down with this, and everybody is stressed out. So I think the best thing we can do is just embrace grace and be kind and be understanding. When you get yelled at, just try to let it roll off your shoulders. I realize that's hard. It's a hard thing to do, and it's not in our nature, but this is the time we need to let it roll off our back. It's better for the people that we would normally cut their heads off, and it's better for us ultimately. Just getting wrapped up in that drags everybody down, and we just ain't got time for that.
Yeah.
So be careful, guys. I appreciate what you're doing.
Agreed. Brandon, I'll give you a shot here.
Oh man, look, I just thanks for letting me join for a few. Yeah, as Jeff said, let's try to be patient with each other. We're far from having this thing licked, right? We're figuring it out as we go, and it's a marathon, so don't burn yourself out too early. Get rest, take care of yourself, have a little fun when you can on your days off, and we're in for the long haul. So you guys are doing great work.
Amen.
Thanks for having me for a few.
Yeah, thanks for jumping up, and thanks for everybody that tuned in, participated with us. We're gonna get on out of here. I know I'm gonna go eat dinner, and it's like midnight where everyone else is at. I have no idea, but thanks for joining us for this little happy hour that we did. We'll probably do this a little bit more often, right? No one's got. If you're not working, you're stuck at home, so why not be stuck?
I think it's great. It's really, you know, I couldn't see y'all in Oregon. You know, now the sad news is out that I won't see you in Tennessee.
Yeah.
So seeing you here is good. I like hearing your voices. It's good to see my friends, even if it's over my computer screen.
Yeah, it's been good. And you know, speaking of having to cancel Fast 20, Brandon, you were out of a job.
Yeah.
No, my family's gonna put up with me for the whole weekend now while I'm home. So 21 is gonna be epic though. So you guys start planning travel, right?
It is gonna be
absolutely. And where is it gonna be?
Yeah, if you did not hear, Fast 21 in Vegas. It's
Vegas, baby.
Go check the FlightBrideED page. We've released it. It's gonna be pretty awesome.
Vegas, baby.
I'm just trying to be calm about it because I'm super excited. Like it's gonna be pretty next level. So it should be really awesome. So book your travel, man. Get to Vegas.
Yeah, I hear we're gonna have tigers.
There's going to be tigers, and Brandon's actually going to be. We're going to give him a bunch of his piercings here. He's going to have one in his eyebrow. Yeah. He's going to get the mullet, and he's going to come in as the Tiger King and host.
I've got the EMS bomber jacket. I'm going to borrow Tyler's white pants. So I'm going to.
There you go.
We'll be good to go.
Exactly. It's
tiger stripe pants.
It's going to be good.
In Tyler tight.
That's right.
All right, let's get out of here. Thanks for joining us, guys. We will see you on the next one. Have a great night. Stay safe.
See ya.